I'd like to say hi to everybody out there. My name is Miguel Montero Baker. I'm one of the vascular surgeons at Baylor College of Medicine, Division of Vascular Surgery and Endovascular Therapies. And I am here in Houston, Texas. What you observe in the back is the medical center. A medical center, obviously, with a big history for advances in cardiovascular medicine. And it'll be my pleasure to join you during Icarus for the latest and greatest in advancements of vascular and endovascular care. I hope you can join us, and I'm very excited to see you soon online. Stay safe. Pura vida.
And I want to welcome our guests, our colleagues, Grzegorz Halena from Gdańsk. It's nice to see you. Dr. Wojtaszek, I haven't seen you so long. He's Polish interventional radiologist working in UK. Tomasz Baltrunas from Vilnius. It's great to see you. And Jan Skowroński from Birmingham.
It's great to see you too.
And also,
again,
because we were talking with Jan at the beginning of our webinar that we were looking for the ladies.
Yeah.
And I found another lady from Poland, from Bydgoszcz. She is wonderful.
Oh, yeah.
And she is a wonderful specialist. And so I want to welcome Joanna Wiśniewska and Artur Mieczkowski from Bydgoszcz. So let's go. The problem is with Miguel Montero Baker, who will be a little bit late. So we will start with Grzegorz Halena with his topic, rendezvous technique for femoral recanalization. Grzegorz, floor is yours.
Hi, my name is Grzegorz Halena. I'm a vascular surgeon working at a medical university of Gdańsk, which is a city located in the north of Poland. Let's just jump on.
Okay, I'm starting to share the screen. Let me know if it works. Okay, so good evening, everybody. My job, I guess, is to convince you that going retrogradely is an essential part of every interventionist armamentarium. And, you know, there are many ways to do that. If you go above the knee for P1 segment or distal SFA, many people use support catheters or 4-French sheets or 5-French sheets, but then at the end, there's the problem of outside compression or using intravascular balloon tamponade because using 2 or 3 millimeter distal axis diameter. So historically, people started with P2 axis, but this is cumbersome because the patient has to be in a prone position. And again, probably you would use a 4-5-inch sheet, and again, intravascular balloon tamponade and outside compression at the end. I think that nowadays we tend to go sheetless from below the knee. You can go with a 4-French sheet if it's proximal anterior tibial, but I had one case of AV fistula as due to 4-French sheet use. But I think that it doesn't make any sense to use very distal retrograde access for our daily cases in the distal SFA or P1 segment. This is another patient of mine, P2 access, and you see there's a lot of calcium, so it had to be done in a prone position. And I had to use sheath because maneuverability and pushability from the catheter.
So,
but then again, at the end, there was a problem of intravascular ballooning and securing bleeding. So this is, I guess, this is the majority of our patients when we have a distal SFA occlusion and relatively free from disease P1 segment, sometimes also distal SFA. So the question is, do I have to go below the knee to get retrograde access? These are some anatomical considerations. As you see, the vein is well behind the artery, so there's no conflict here, no risk of AV fistula. There's a straightforward way of getting into the artery. So after my first catastrophic experiences with using a 6-French sheet for retrograde, I switched to 4-French, as you see here in the picture. But again, in the end, you have to use intravascular ballooning and outside compression. And of course, vascular closure devices are probably off-label. I don't think anybody uses them in that region. So the question is, can my diameter of my intervention of my distal axis can be even smaller? Because if you use a 4-French sheet, you create a hole of 2.5 millimeters. And this is my daily driver, I'm using a simple, very simple, unsophisticated tools, which is a O18 compatible Pacific class balloon from Medtronic, which has a diameter of less than 1 millimeter. I use this as a support catheter. I used CXI from Cook in the past. It was too slippery. If you broke the tip, it was completely useless. So I switched to a very simple device, and this is my ensemble. A regular needle, V18 guide wire, which has a very stiff steel core, and a new, fresh, undeployed O18 compatible balloon as a support catheter. And it works in the majority of cases. So this is a typical case, 5-7 centimeters of calcium to cross, and you think you cross and you end up being subintimal. And I don't think it makes much sense to spend more than 10-15 minutes to try to get back into the intraluminal portion of the P1, because you enlarge the dissection in the subintimal space. So what I do today, I immediately switch to puncturing the P1 segment of the popliteal artery. I use the V18 guide wire, and it works. And of course, I'm using the O18 compatible balloon. This is Fox. Sorry, this is not a Fox. This is the one from Medtronic. You see the markers of the balloon. This is enough to cross the majority of lesions without. Of course, you lose torqueability and maneuverability, but works in many cases. If you have problems with the wire rendezvous, which is the most desired option, this is the second option that I use. This is a reverse card technique. I use a balloon, but I bring the balloon from above. I never inflate the balloon. I insert it sheathlessly from below. And it works again with the majority of cases. Again, I don't use the card technique. I prefer the reverse card technique. And this is how it works. You bring another balloon from above, you rupture the membrane, and by gently torquing and pushing, the V18 guide wire will find a way to the true lumen of the superficial femoral artery, as you can see here. And of course, navigating to the catheter or the sheath with a V18 guide wire is relatively easy, and you end up with a through 300 centimeter guide wire through the femoral axis and through the distal puncture axis size. And then keeping the wire in place, all you have to do is have to remove the balloon. You just insert it from below, and you use the same balloon and insert it from above through the femoral sheath. You bring it down, and of course you cross the puncture site further, but you have to flip the guide wire because the hard end of the guide wire has to be switched for the soft end of the guide wire. Sorry, I go back. Okay, yeah. Yes, you can see on the right, inflating the puncture site usually takes me 2 minutes to secure bleeding. There's no bleeding afterwards. If I see some leakage, I repeat the ballooning another 2 minutes, and this is enough for the majority of patients. Okay. And this is the final result. As you see, 2 minutes of ballooning, no bleeding. Of course, the patient had to be stented because of the calcium. You can appreciate. As much as I like working from the ipsilar going downstream, in those cases, when you anticipate distal puncture, I think it's much more convenient for the operator to work from the contrast approach because you don't have to move. You stand in one place and you control both the femoral sheath and the distal puncture sheath with your hands without moving anywhere. And in some cases, it's even difficult to cross the lesion with the O18 balloon. Then you can use gentle traction, pulling both ends of the V18 guide wire to cross the lesion. And this is how it looks at the end. As you see, no bleeding, no external compression, no VCD devices, no hematoma. So in conclusion, ladies and gentlemen, sheathless P1 approach using the 3 simple tools I just showed you successful in 80 to 90% of cases. You can always upsize to a full French sheath or support catheter of your choice, but then you make the hole bigger. You don't need extra tools. You don't need any external compression. And of course, you minimize the distal axis diameter, and therefore you minimize complications. And for the majority of my patients, 2 minutes of ballooning is enough to stop bleeding. Thank you very much.
So, Grzegorz, how often do you use popliteal access?
Okay, how often do I use it? Well, I try to go antegrade as much as I can, but as I said before, I think that in 10% of SFA cases, you need some form of retrograde access. And I found this one to be the easiest, the quickest. There's no excuse that I don't have a support catheter or appropriate sheath. You always have the guide wire, you always have the balloon, and you always have the needle. And of course, my advice is always prep the patient before if you anticipate retrograde stick, because that, again, you save time. You spend 2 additional minutes at the beginning of the procedure, and then at the end, during the procedure, you have to think, you just, anesthetize the skin and just stick your needle into the tibial, so into the P1, P2, P3, whatever, wherever.
Thank you. So we have Grzegorz Oszkinis.
Yes, Grzegorz, I have a question because at the past session we were talking about the time-consuming procedures. In your hand, how long it takes to do this kind of procedure you have shown us?
Well, as I said before, I usually spend 10, maximum 15 minutes trying to cross from the antegrade. And if that fails, I immediately switch to retrograde stick. And I think it takes another 15 minutes maximum. So it's not a...
Thank you very much. Okay. So let's go to UK. Mikołaj, could you tell us about the venous arterialization? It's well known right now, the procedure. I don't think it's easy. We have a special device, but this device is very expensive. I think that many of us are not able to use it, and we can afford, especially in Poland. But you will show us how to do it easier and cheaper.
Definitely, yeah, definitely. And it also bases upon retrograde access, which Greg just showed us, just in a slightly different location. So first, just to define the clinical problem, we have something called the SAD foot, and that's small arterial disease inside the foot itself. And these are going to be whole patients with diabetes, renal failure, or patients with, the frequent flyers with previous arterial disease that was, we've been treating them and they keep coming back. Yeah. So at some point, these patients are going to develop a no rescue situation. And these are the patients that could potentially be eligible for venous arterialization. We have to differentiate between the bad patients, that means the large vessel disease and the small vessel disease. And there's also a very useful scale, the SCAD scoring system with the degrees from 0 to 3, from 0 to 2, showing you the various stages of progression of this disease. So once we're in this kind of situation, we know that there's no other option that we can offer, and most likely these patients will not heal on best medical therapy. Where are we with best medical therapy? We are getting better, and there's a study from 2012 and then repeated in 2015, a meta-analysis showing that we are progressively, the drugs are getting good enough to get us out of a lot of troubles just by using them, just by thinning the blood. But still, we have 20% of patients that will only heal, but the rest will have some kind of dire consequences involving death, amputation, or non-healing wounds. And we're talking about Rutherford 5s and 6. So these are patients that have a very meager quality of life, and they're generally very poorly. Now, as Professor Oszkinis mentioned, there is a dedicated device, the LymphFlow, and that's where most of the data come from. But the method is not new. The endovascular approach is fairly new, but the method itself has been used by our Russian colleagues previously. I think it's got maybe 50 or 60 years on it. The surgical connection between the arterial system and the deep venous system to reversely perfuse the ischemic foot. Other options that are still under investigation would be the stem cells. But what we're here to talk about, unfortunately, the trials have been ongoing, but there's not a lot of positive news coming from these trials, unfortunately. While these methods, the endovascular methods, are being heavily promoted. Most of the data, like I said, is from the LymphFlow methods, but there's also the Piper technique and the VAS technique, which I use, and these are the people behind these homemade techniques. Fabulous guys, I have to say that they're wonderful people, very helpful when it comes to initiating a service, and very knowledgeable also when it comes to these diseases. Like I mentioned, the general principle is to connect the artery to the deep venous system and retrogradely perfuse the foot through the venous system. When it comes to clinical data, unfortunately, most of the data is collected from the LymphFlow program, but as you look at the numbers, there's really not a lot of patients coming in. The pilot study, the PROMISE, and the PROMISE International study did not really have a lot of patients, while they had a lot of centers involved. So nobody really has a tremendous amount of experience in this method, with everybody amounting to a couple of cases. And all of us are trying to reach the conclusions whether this is worth it or not. And in some cases, I guess it is. Not everywhere, though. Wound healing. We can see that from the lymph node data, we do have a progressive amount of wound healing in the first 9 months, which is fabulous. But if you look at the amputation-free survivals, they're still going to be around 80 to 70%, which really doesn't make it different from best medical treatment. So DVAs for now are not a game changer when it comes to this. It's just another method in our toolbox, a bit like the retrograde approach, a bit like other stuff that we do routinely. It has to be considered, but it's nothing like the holy grail of CLI fighters. Yeah? And the ALPS multi-center registry is also another database of data, also involving the lymph node device, and it also repeats on an all-comer basis what the trials have already shown. That means that there is an amputation-free survival of around 70% after 1 and 2 years after the procedure. Now, because we're going to be talking about cheaper devices than the lymph node, we got 2 different techniques, at least 2 different techniques that I'm aware of. One is the Piper technique, which uses an IVUS, the Pioneer IVUS, and then uses a re-entry catheter to transfer from the posterior tibial artery to the posterior tibial vein, and then exactly the same way as a lymph node device would do it, we create the fistula and repeat blood flow down into the foot. Now, this is more a radiology kind of friendly device because it just uses fluoro beams. There's no ultrasound, there's no costly IVUS, and the only thing that you have when it comes to the cost of the materials is the 2 snares and a couple of wire bands. So it's nothing really different than the materials we normally use. So this is one of my patients, a patient that is what we call a frequent flyer, very distal disease. I've recanalized them a couple of times. The posterior tibial, that went on for a bit. Then the anterior tibial, the posterior tibial closed, and gone again. A couple of weeks, a couple of months down the line, and no progress when it comes to healing of his wounds. So at some point, we decided, and I did a lot of crazy stuff. I tried to puncture the plantar artery to recanalize the posterior tibial retrogradely. That didn't really work out that much. But yeah, I tried my best. And at some point, I just exploited every endovascular arterial option that I could think of. So venous arterialization would be the next. Now, when it comes to approach, we're looking at having an antegrade approach because we want to shorten the distance from the 2 connections as much as possible. We're going to be using any chitinal snare would actually do. And under ultrasound, you target one of these veins. The posterior tibial artery has 2 veins that go around it. Whenever one is easier to puncture, you puncture that. You put a French sheath in, and you have bilateral access, one from the arterial side and one from the venous side. Afterwards, you align 2 snares, and this is the crucial part. Through the skin, you puncture, bullseye technique, you puncture through the snares so that the needle goes through 2 braids of the snare, and then you put a wire in, and I usually put a 018 260 centimeter Terumo because it has enough flexibility so they can bend on both sides. And then you progressively, you take one of the part of the wire out from one side, and then the remaining part of the wire out from the 2 sides, creating a wire joint arteriovenous fistula. Now, this isn't the end of the work that you have to do. Then you have to start connecting the veins on the foot. Now, what you're looking at is there's 4 groups of veins. You got the deep plantar veins, and you got the superficial dorsal veins. So this is the deep venous system, number 3, and this is the superficial system. So you want to proximally connect the arterial supply to the deep venous supply, let that flow into the foot, and release it through the superficial venous system. So you need to connect number 3 and number 1. This is a superficial vein, while this is the dorsalis pedis vein. It's also a deep vein, so you want to avoid this and just make sure that you have a nice loop coming into the superficial venous system. There's a couple of tricks that you need to know before you actually start doing these, and that's about basic venous anatomy. once you do your angiography and you can see the outflow of venous blood the way you want it, you do aggressive angioplasty using a 4 and 5 millimeter balloon. Make sure you connect that up to the point of the fistula, and then you start stenting that with Viaband stents from top to bottom. Now, it's also important not to finish the Viabands too early on, because over at the calcaneum, you have the tarsal tunnel. Now, the tarsal tunnel is a thick band of ligament that actually compresses a lot of the things. You got a couple of veins here, you got the artery, and you got the vein here. And unfortunately, the way it's built, it compresses whatever you do over here. So you have to have the stent going under the tarsal tunnel. Otherwise, the entire procedure will not work. So as you can see here, we tend to put the stent in a bit lower than we'd normally think, intuition would dictate. Here, the stent, I have to admit, is a bit too low. You have the very characteristic valve around the calcaneum around here. So you need to also break that either with a balloon or with a stent, and then balloon it out. And then you have that nice flow of blood through the fistula, through the deep venous system, and then release into the superficial venous system. Now, like I said, there are a couple of mistakes in the way this procedure was done, minor mistakes, but I have to say that being a bit of a pedantic guy, they really kind of ail me in a way. Like I said, the stent is slightly too low. It could have been released at least 2 centimeters higher up. And also that kind of venous fistulization that you have here, that there's too much early venous release of the arterial supply of the blood, is also a bit of a mistake. Technically, this procedure could have been done slightly better. On the foot, what you're aiming to is, and this is something that it's not a lot of people talk about it, but Bruno Migliari, the author of the Piper technique, says that it is actually quite an important element of the game, is to devolve the veins up until the first main vein of the first toe. So you really want to get back inside, and with a 3 millimeter balloon, try to balloon this vein over here. This gives you more flow into the forefoot, which will also promote healing. What is worrying about the procedure, because like I said, the procedure is technically quite simple, is what happens afterwards. And afterwards, a lot of things happen, and we call it generally the venous storm, because there's so much blood rushing in from the venous system, and the outflow really can't cope with that amount of arterial blood. We have a bit of venous stagnation, but also we have the Venturi effect, which by the amount of blood coursing through the forefoot steals a bit of arterial blood from the toes. Therefore, the patients will have both swelling and steal syndrome in the distal part of the toes. So unfortunately, if you have, for example, dry gangrene, a lot of that, because of that venous stagnation, is going to turn into wet gangrene. And there's a couple of things that might go on, for example, a bit of dieback. And honestly, the first couple of days, it doesn't look pretty. What you're aiming for, unfortunately, because there's little chance you're going to be able to reverse the steal syndrome in the distal parts of the toes, you are looking for a forefoot amputation. But you don't want to do this too early on around the procedure or after the procedure, because you want the PO2s to increase to such a level in which a tension-free flap can be sustained after the amputation. So this can't be done early on. You're trying to wait around 6 weeks after the procedure, and by that time you have to debride, you have to get all the stuff out, treat with antibiotics, treat the swelling in order to prevent any kind of infection and dieback in the places that don't look too healthy. And gradually, the PO2s will increase, and you will get your desired effect of lower limb salvage. So initially, the 24/7 close-up follow-up is super important, and management of the pain, because ischemic pain, when it comes to stealing of blood from the toes, is super painful. So you're looking at perineural epidural catheters and keeping the patient in for at least a couple of days, if not weeks, after the procedure. This is not a procedure that can be done under a day case. Venous overload is going to be scary for you, less so for the patient who doesn't usually know what's going on, but you are going to be worried about the stagnation of blood flow inside the foot, because it just doesn't look pretty. The foot is nice and warm, but you have to be aware that most of the blood is coursing through the venous system, and before the arterial bed arterializes and all the collaterals develop at a cellular level, that was still going to take some time. patients, you are going to be tempted just to abandon the procedure and say, let's cut off the leg and just, get rid of the problem. But if you do wait it out, you might get the desired effect. You won't always get the desired effect, and still 30 or 40% of the patients will end up with an amputation. So be aware of this. And then bring a tissue to the flow. Be aggressive about this. Always prepare for a forefoot amputation. Don't think about saving the toes too much. When it comes to post-procedural management, blood thinners, this is important. There's no consensus about which ones to use. We use vitamin K inhibitors with a single antiplatelets, but I've heard people use dual antiplatelets with a vitamin K inhibitor, and there's also people using DOACs with clopidogrel. Whatever you want, you have to do both antiplatelet and anticoagulation at the same time. When it comes to imaging, always think about on-demand angiovenography whenever you're worried about having too much dieback, for example, or things not progressing day by day. You want the way you want it, because sometimes you will have to focalize flow, and I'll show that in the next slide. Post-procedural duplexes, if the flow is under 100 mils per minute, you are in dire straits. You might be having a fistula malfunction, and you will have to address that also with an angiovenography. If you have PO2 monitoring, and I know not everybody does, you looking at these values, and if they start increase, you're in the good zone, you're in the green zone. If something happens with the PO2 values and they start declining, that means you are having early dysfunction of your fistula. So technically, procedure is quite simple. It's the patient management afterwards that is causing most of the problems. Now, if you do have dieback, for example, around these procedures, you might want to intervene once again and see, for example, to cut off all the draining routes to get even more arterial blood pumping inside the tissues, trying to perfuse and open up all those latent, dormant arteriovenous collaterals in the meaty part of the foot. This is how these coiling looks like. So from this, if you close off all the deep draining veins and just have flow into the deep venous system, one route and one route outflow, you are going to concentrate more of that blood, more of that arterial blood into that ischemic tissue bed, which is what you're looking for. Arterial occlusions, these happen a lot. Everybody reports them. At least half of the patients, maybe not at least half, but around half of the patients, you have to prepare that you are going to re-intervene and try to open this up again. You don't want this to last forever. You want this to last at least 6 weeks, hopefully a couple of months, before all these latent dormant collaterals down in the foot develop. So secondary patency, tertiary patency, quadruplacial patency is something that you're at, okay? Never forget that re-intervening is nothing on your slate. You have to do it. You have to keep this going as much as possible. Everybody is reporting patency loss and secondary interventions. This is a complication that you want to avoid at all costs. And this happens when you get venous thrombosis. You can get this, for example, sometimes if you do flow focalization too early in the game. If you do it as a one-stage procedure, do the fistula, and then close off all the draining routes, this might happen early on. That's why we defer flow focalization to at least 2 weeks after the initial procedure, sometimes even more. If there's no dieback or you're not really worried about how the wound is progressing, then you don't have to do it. But it is recommended that at some point you try to have one straight route into the deep venous system with one straight outflow. If you get this, it's game over. It's fulminant, and only amputation is the way to go, unfortunately. Fortunately, it doesn't really happen a lot, and if you keep to the pointers, it won't happen to you. Thank you very much. Any questions, further discussion, I'm willing to take them on.
So thank you for your excellent presentation. And my short question is, your typical patient, let's say during the first 2 months, how many reinterventions on the average you have to perform?
Whenever you're worried, so it might be up to 2-3 interventions even. You really want to not neglect these. I mean, nobody has tens of patients, hundreds of patients to be able to say, okay, this is the point when it's okay. Yeah, up to here it's okay. We're so used to treating arterial patients, to demarcating, to letting things dry out, to giving antibiotics, to mummifying, ischemic toes. This patient turns bad very, very quickly. And like I said, most of the things is that you have no idea what's going on. You have a swollen foot, you have the development of gangrene, and you're thinking, okay, we're just going to get away with this problem. If you do an angiogram early on, and you can convince, I'm a radiologist, yeah, and you can convince your surgeons that no, let's keep this a bit longer because this is still flowing, and we know that most of the the reversal of flow is going to take a couple of weeks. Then you can stop your surgeon's hands from taking the guy's leg off. So whenever necessary, whenever you're worried about things, you have to have that kind of documentation because you're just worried, yeah? It's a bit like, you have a kid. Is he okay? Is he sleeping? Is he, if you went to bed, is he still breathing? Yeah? It's like we're all of this behaving like with a child. We just don't really know all the spectrum of things that might happen. So we're looking at it super closely. And tell me, from an interventionist perspective, do you really trust your Doppler or you like the angio pictures?
Angio.
Exactly. Yeah. So whenever you need to, you have to, it has to be part of the consent process. We're doing this procedure. We will most likely have to go around a couple of times, make sure that everything is going right. Yeah.
Okay. Thank you very much.
Nicolas, this is Miguel Montero Baker from Houston. I'm sorry, I just kind of got the little tailwind of your presentation, and it's very interesting because this is exactly what I was doing right now. I was doing a serialization, and so I was wondering, when I have very high flow volumes, I find that these patients become very ischemic, as you were saying. And have you found the sweet spot in your own research of what the flow volumes that lead to good wound healing versus those that just create an absolute mayhem and ischemic toes in the first few hours?
I don't think we can avoid the ischemic toes. You get a massive Venturi effect with all the blood rushing out from the foot, and it's just stealing all that excess arterial blood that that tried to seep in there anyway. I think it's a bit like with a TIPS procedure. You oversize the stent, you get too much flow volume, like you said, and then you have this kind of dire effect. Everybody's using 5mm stents, but like you said, the volumes are still unpredictable. Yeah.
We've been able to carry on a very systematic follow-up, and we're about to publish that data. But we've come to understand that the sweet spot's about 250. So
250 when it comes per minute, yeah?
Yeah. So if we get flows in the 400s, those are patients that usually have strong pulsatile pain in the plexus and or very severe ischemic pain. So those are the patients that in a second look, we'll bring them back within, who knows, less than a week, hopefully, and do embolization and focalization, because as you limit the outflow vessels, then obviously the fistula drops its volume, and a majority of the patients actually get asymptomatic. But kudos for your efforts, because these patients are truly those that we don't have a lot to offer. And unfortunately, as you'll see, they're coming up more. And you'll see in my presentation why the reason they're going to get even more and more in our clinics. So very good. I congratulate you on your efforts.
Thanks, Miguel.
This is Jan Skowronski, Mikołaj. Congratulations on your cases. I haven't done it, but I love the technique with 2 snare devices. I think it's brilliant. I think it's relatively simple and it's intuitive.
It's super simple, and you'd be, once you start. I mean, this is what I learned from the guys from Spain. Yeah, August Isa, fabulous guy. But honestly, I use a double snare technique now in a lot of arterial interventions, purely arterial.
So Mikołaj, here is the dilemma. These are not easy cases. They are high-end cases, no matter how you look at it. And in order to do high-end cases, you need to actually learn how to do them. So on one hand, you see it and you can try it on your own. On the other hand, you have some potentially early commercially available systems or a system, but that costs like $10,000–$15,000.
But Miguel, are you using the?
But you have all the support you can get from the industry. On the other hand, you can learn on your own. Fairly simple technique, not that simple, but it's super cheap. So here is the dilemma that I see. Thank you.
It is a dilemma. Miguel, do you use the lymph flow device or do you do homemade?
So currently, I've been doing this now for 3 years, and so until approximately 2 months ago, 3 months ago maybe, that we got off the ground with a PROMISE 2 study, The FDA is incredibly stringent, specifically with this kind of out of the box thing. So it's not entirely straightforward, and it's a limited number of patients that actually can get into the lymph flow study currently. So we have been using it, but what we do the most is off the shelf, as you have all brilliantly explained before. And yes, August Isa has taught me a trick or two before. It's great to have Twitter and global education because we're all stealing little tricks from each other around the globe.
Exactly. Yeah, I hooked up with him on LinkedIn, and it's a fabulous community that we're developing over there. I have to say, yeah. Good. Kudos.
Thank you. Grzegorz, back to you.
Do you hear me? Nikt mnie nie słyszy.
Yes. We can hear you. We are
okay. All right. Okay. So, Miguel, welcome. Why do you use a facial mask? Are you afraid of us?
Unfortunately, I'm working in the cath lab, and I'm in an area where there's other people going in and out of the cath lab, and we're have extreme measures for COVID. So
okay.
I apologize. I'm not alone in a room where you could see my but trust me, I'm doing everybody a favor by not showing my ugly mug. Okay. So,
but anyway, thank you.
It's my turn, I believe, in the presentation, or do we have somebody else?
No, before we have Joanna Wiśniewska and Artur Mieczkowski. They will showcase with for French device. Yes, please go ahead.
You see, I can see they're not doing social distancing that well.
One moment, please. Welcome to Icarus.
Second. Can you see presentation right now?
We can see very well. Thank you.
Thank you. We would like to present some benefits of using for French compatible device while treating some more popliteal disease. And we will try to answer this question.
So when you think about for French compatible devices, you can think in two ways. You can want the procedures as less invasive as possible, or you can get more possibilities using a bigger sheet. As the first thing, when you compare incision area, when you use 6 French sheet and 4 French sheet, using smaller sheet give you almost 50% smaller hole. So because of this, you don't need to use any closure device. You can press the incision area in a shorter period of time. And because of this, you have much less complications like local hematoma. It was found already a few years ago that it might be almost 10 times less complication in incision area. And these hematomas after 4 French sheet don't need any surgical repair. And what more, you can perform whole procedure with one long sheet, and 4 French compatible devices have lower profile, so it's easier to go through difficult lesions, and also the wires which you need to use are more gentle, so you can use it in a smaller vessel, for example, below the knee, not only in femoral popliteal. And also you use a lower dose of contrast, so you have a lot of benefits for patient. You have lower bleeding risk, you have lower risk of injury, and also in a difficult patient who have many scar tissue or highly calcified vessel, you can use a radial access or retrograde access. And as you can see, when you compare the profile of the 4 French compatible device with, let's say, standard device, in an example of Paseo, when you see the Paseo 8 in the profile is much lower, so it's really easy to use it in a smaller vessel than in difficult lesions. And what was mentioned before, also the wall of the stent in a 4 French compatible devices are much smaller, so especially in small vessels, using this stent gives you bigger flow area in the artery. But there are also some limitations. You cannot use any thromboaspiration. Not only all atherectomy systems works with 4 French, only Diamondback work with this. And also you cannot use Outback or Frontrunner or use stent graft. But what we do very often using 4 French compatible devices, you also use a bigger sheet.
just to have more possibilities. You can use any guide wire size, all balloon size, all other techniques like you can use kissing stent, kissing balloons techniques, and easily treat any complication which might happen during procedure. And in our cases, most of these patients have some medical histories and also vascular history. I will not explain every patient, but only the scans. This is how it should look when you use Fort French sheet going ipsilateral antegrade. You can use, for example, B18 guide wire, and then some balloon, might be drug-eluting balloon like Passau in this case. As you can see, this patient has a really narrow artery, so after PTA, and due to these sections, we also use the stent, which we choose Pulsar 18, which, as I mentioned before, has a bigger flow of the area inside of the stent. And this is how it should work in most cases, but sometimes it's not so easy. Also using small devices, for French compatible devices, you can also go retrograde, like in this case, we choose the tibial anterior artery and Navicross with B14 guide wire. Then we do some angioplasty and have a really nice result. As you can see here, is the stent is also the Pulsar 18 in the flexible area of the knee. The outcome was really nice. But sometimes also the femoral popliteal occlusive disease doesn't end at popliteal. In this case, we choose the ipsilateral antegrade access with a bigger sheet with 6 French. We use the B18 guide wire and balloon angioplasty with Bantam. But unfortunately, after this, we find some complication like this rupture. And because we used the bigger sheet, we can easily repair it. First, it was a prolonged PTA, but it doesn't give really good effect. So we decided to put the stent inside, and the final result is quite nice, and the flow to the foot is really good. And as you can see, using a Pulsar stent and in the knee area, even when you flex the knee, the stent behaves really nice. We don't have any fractures, and the flow is not limited even when the patient will move and go down on his knees. Another situation when the disease doesn't end at a popliteal artery, as you can see in the second scan, there's almost nothing below the knee. Again, we use the bigger sheet just to have more opportunities. Firstly, we do angioplasty with 4 French compatible balloon, but then we have not really a good result. Below the knee, as you can see, tibial anterior arteriole almost doesn't exist, and the tibial fibular trunk has some dissections. So we choose to use 2 balloons to kissing balloon technique, but after this there was, I don't know if it's seen good, some clot in the bifurcation. So we choose to put kissing stent in this place, which is easily to do with bigger sheet. And the final result was like this, and the flow to the foot was really nice. And another situation, very similar, you can also, with using bigger sheet and 4 French compatible device, you can easily secure another artery when you need to put the stent, for example, in tibial anterior artery, like in this case. Or kissing stents again, as I mentioned before. And also you can use 4 French compatible device and angio-CO2 in the same case. So you can connect many equipment and get really nice results in any problems with superficial femoral artery and below. And not only this, but it's not the topic of today's presentation. You can use this also to fistula or something like this.
As a summary, we would like to underline most important things. So using 4 French sheet below inguinal ligamentum give you possibility to perform most procedures with a lower rate of complications. And second thing, that if you want to use for French compatible devices, you can also use a bigger sheet to receive more treatment options and easily deal with complications.
Thank you very much. If you have any questions, feel free to ask us right now or later by email.
To our colleagues.
Miguel, you're running it. You're on.
Yes, I really appreciate this. Now, one of the things that we've been doing more and more is seeking transpedal approach for a lot of these procedures, and I think that you know, despite all the great things that you guys already said, I would add to that there is a group of patients that may just get excellent results from getting a small 4 French sheath, and you can do an entire intervention and put a TR band for radial intervention and literally have the patient walking within less than 1 hour of their procedure. Would you care to comment if you've had any experience in deploying this device from the 4 French transpedal approach? And if not, do you believe that that may be something interesting for patient care?
With the pedal access, yeah, we sometimes do this, but in most cases we don't use the sheet, but only guide wire and catheter like Navicross, for example. But sometimes if you need to, of course, you can use 4 French sheet. Before this, you should inject nitroglycerin, I think.
So what we sometimes do with some of our patients that are very obese or have radiation of the groins, if what we're looking is an SFA intervention and they have very juicy tibial vessels, what we'll put is a micro 4 French Terumo, do the procedure, and then even through that, you could actually deploy this particular stent because of its low profile. Yeah. So I think that's a great opportunity where you don't even have to mess with a complicated groin and or have to upsize your sheath.
Yeah, of course, especially among obese patients, it's good.
Well, I use a lot of 4 French below the knee punctures, and honestly, I'm not really actually convinced that the radial band or any kind of compression is necessary. Most of these holes just close up by the time you compress it for like 10 minutes, yeah, or 5 minutes. It's not really necessary, honestly. Yeah.
It's cheaper to have a fellow put a finger than use a TR band, right?
Yeah, that's what I mean. Yeah, yeah. It just doesn't happen. I think for the past 4 years, I think I've only had 1 bleed, and that was after tibia peroneal puncture in a patient on dual antiplatelets. So kind of fat, wobbly legs and stuff like that. But otherwise, there's just no bleeding after these punctures. Absolutely, they can be up in about even less than an hour, in my opinion.
And do you guys know, again, this is just ignorance on my end, what's the longest 4 French stent scaffold that there is out there on, let's say, a standard 6 millimeter for SFA? What's the longest one you could get?
200.
Can you repeat the question?
The longest 4 French stent that's available commercially. I just don't know, and I don't use it that much.
Miguel, 200 millimeters.
Oh, sorry, team is going to be a 200 stent.
100?
200.
200.
200. Okay, that's a very interesting.
The thing is that you have to remember that the pulsar is a very low radial force stent. It's actually not, for occlusions, it's not a super stent. It's fabulous if you have, for example, dissections, something that is like fairly soft plaque. But if you want to cross the occlusion and you put a pulsar 18 in, it just doesn't really work for long. You have to have something with a bit more radial force.
Understood.
There's also a sinus.
This is Jan Skowronski. I think Miguel will have to move forward.
Okay.
Yes, please.
A couple of our panelists from the next
tell
session
me how we're doing
have another commitment.
Okay, fantastic. Let me go straight to this presentation then. And obviously, first of all, appreciate the invitation, Jan. You've done a phenomenal job here. I'm in the middle of the cath lab in Houston, in Texas. And to avoid a ugly wall, I decided to put this space thing because we're about to hopefully throw a new spaceship in this upcoming Saturday. So anyway, celebration of what Houston was and maybe will be again, Space City here for you. I wanted to bring together a lot of these concepts into this contemporary management of CLTI patients. I don't have any particular disclosures to go against this slide set, but I believe that times have changed. And I think all of us today in the last two sessions have shown what we're seeing, which is we're not necessarily pursuing so many of these Marlboro men with high, big aortic occlusions, but we're getting really populated with a bunch of patients with diabetes and extensive below the knee tibial disease. Obviously, on top of that, many of these patients have renal failure. And if you look at the impact of such calcification patterns, we look at contractile normal smooth muscle that eventually becomes an osteochondritic smooth muscle. So we're getting medial calcifications. And if we only look at where dialysis is going, I think that we're looking at some very extensive disease patterns of this, which I believe is the nightmare for everybody. And I think the second to last presentation was phenomenal in stating what can we do for some of these patients as we move forward. Now, I believe that this may not be the same all around the world, but here in America, every block or two, you have what we call vein annihilating centers, and all they do is they sap everything that comes into contact, because it's been becoming a booming, unfortunately, business, and it's driven a lot of the reimbursement in the venous market that ends up killing all GSVs or saphenous veins. And on top of that, we have a very, very old population with projections of a complete change for 2050, where we're going to have 39% of patients above 70 years old. Unfortunately, they don't all look like Schwarzenegger. They all usually look like this. And we certainly have and understand what physiologic reserve means and how in increasing age this drops, defining what we call the geriatric syndrome, reflecting a state of decreased physiologic reserve and vulnerability to stressors, which increases the risks of adverse outcomes, including falls, delirium, and disability. So I believe if we can create a succinct status of the current times, we have an older and more frail population. We have a dramatic change in disease patterns secondary to the rise of diabetes and renal failure. Adequate conduit is becoming a rare commodity for us vascular surgeons, and precision medicine, and especially personalized care, I believe is going to become more of an issue. Now, many scenarios that we have to look at, and this is kind of how we do it here in the Save the Extremity program at Baylor College of Medicine, but we determine your indication. We look at Wi-Fi scores, which include wound, ischemia, and foot infection. We determine the frayability and nutritional status by certain wearable sensors that we have ongoing studies with. Obviously, anatomy of disease, which today we've probably gone away from task and accepted more of the global vascular guidelines, and the determination of conduit, and or if this is good conduit or not conduit. We're also looking at an ischemic threshold and what that ischemic threshold is, which probably has to do with the patterns of disease, the wound care, and the advances of wound care or networking even that the patient may or may not have, and the comorbidities and the nutritional status that that patient may have. That determines this ischemic threshold. This is Conti. Conti is the chief of San Francisco. He's a very classic, very smart, articulate man, and I could not disagree more with him. And I've said that to his face, where I don't necessarily think you can just create two boxes to determine who should get open and who should get endo, because all of these variables don't become as black and white as it's tried to portray in this paper from 2013. The grays have escalated. This is an oversimplistic approach to a very complex problem. Now, that said, I do agree with Mike in the sense that a lot of the stuff that we have with endo has come in a way where we can't really even stop it. It's a tsunami of products. Sometimes you have even a hard time understanding where you're at. And when you finally understand how to do something, it apparently becomes a thing of the past. So we do have to try to create objective performance goals and good clinical trial designs. And quite frankly, thus far for chronic limb-threatening ischemia, I think we are behind the 8 ball. So determining what's sexy versus what's better, that's something that we have to try to define in a more, a broader way. Surgery continues to be surgery, and it's a very useful thing, but we cannot look away from the fact that there are perioperative morbidities like cardiovascular events, need of blood products. prolonged hospital stays, requirement of skilled nursing facilities and rehab places, surgical site infections, and graft infections. When you look at the mortality, when you compare large data sets, it's interesting that in the complex subset of patients that have CLTI, the mortality could be comparable, although some people believe it's higher with surgery. I also would like to bring a definition that Wi-Fi scores are very much a tool now, because if I pick up the phone and I call my friend in Brazil and I discuss a Rutherford 5, it could be any of these things, or a Rutherford 6 could be any of these things. But having a broader definition of what the type of wound, the extension of the wound, the area of the wound, has a lot to do with what we do to these patients. So we try to look at three spheres where we have the limb status, the patient status, and the anatomy, and try to put all of that into context of having an appropriate classification. We know from some old data, that conduit is absent in up to 40% of the patients. I'll assure you that if we would run this study again in 2020, that is probably dropping down to the 10 to 15% of patients that do have a good conduit. And when I mean a good conduit is a beautiful GSV of 3.5 millimeters or above with no scarring, no evidence of any past acute thrombotic event or insufficiency. When we look at some of the data of distal bypasses for below the knee and extensive disease, certainly the permeability of such bypasses is actually very minimal. And when at some point we had cadaveric veins, which are now for sale at a high price, and you look at the data of cadaveric veins, it's also very detrimental. So I think that those surgical principles haven't changed for the last probably 50, 70 years of our development specialty. You can't work if you don't have a conduit. You can't work if your inflow or outflow are not there, and you can't work it in an inadequate patient. But on the other hand, you hear things like this from this particular article saying CLI patients have a disease pattern that's not amenable to endovascular therapy and require crural bypasses for adequate revasc. Now, I believe that that's just pure baloney. I think that we've developed very adequately our techniques, and we have, as we've shown throughout the hours here of this, techniques that allow us to drive wires anywhere into the distal arteries of the foot. We are able to poke into the smallest vessels if we need to and get retrograde access. And these are cases that I've done here in our facility. But at the same time, when we need them, there's nothing wrong with a beautiful vein and a distal SFA all the way down to the dorsalis pedis bypass, as we've shown in this article. And this was from as soon as last week. So I'm trying to make myself immortalized by quoting myself on a presentation from 2018, because nobody quotes me. So, I mean, you got to just do it for yourself. But I said something like, with the development of robust technical skills and more appropriate technology, operators are able to treat more complex and distal patterns. And this perfect storm of technical skills and advanced tools makes the decision what's possible irrelevant, but the question what's appropriate extremely relevant. And I think that that's probably the area where we should put more efforts. Perfusion, measurement of oxygen, what are the goals? What leads to adequate wound care in what kind of patient? So yeah, you can do everything, but it requires really good specialty training and skills. You want to do distal bypasses, learn how to do them. They're not the same as a FemPop. You want to do distal access, learn. It's not the same. This is kind of how we go here. It's a very quick, and this is my second to last slide. Ischemic lead. Do you need revasc or not? Do you have medical optimization? What's your frailty, your op risk, your renal risk, your anatomy, your venous conduit? And then all of that primarily leads us to an endo-first approach. Determination of technical success and perfusion evaluation. And if adequate, then optimize medically and wound care. If not, you can certainly try again, but always have the ability to revert to open, or the same way, revert to endo from open. So I think it's a very fluid dynamic that you have to have. So in conclusion, my dear friends around the globe, I think this is all about patient and limb-centric approaches. We cannot forget that element in the equation. I think we have to work in hybrid teams or become hybrid doctors ourselves. Be there because we can offer both, or because we have good friends and colleagues that can offer either or when we need it for the patient. And certainly balance out all possible elements into the algorithm of care to try to come out with the best solution for the patient. And with that, I say thank you very much as the Chief of Operations for Vascular Surgery at Baylor and the president in place right now of EndoLab for Latin America. I appreciate your invitation, appreciation to all the team of Icarus, and Jan, thanks for having me here.
It's great to have you. It's wonderful. I think we learned a lot in this session, but it's also, it shows us the power of will, that almost everything is possible, and we see how quickly we are expanding and getting better in what we do. We wouldn't be talking about it 10 years ago, for sure. Thank you. Greg, back to you.
Yes, Miguel, thank you. It was a fantastic presentation, because I'm also a vascular surgeon doing the endo. So we have to talk not only about the endo, we should also talk about the open. Sometimes sometimes it's better for the patient to do the distal bypass than to try many techniques which doesn't work. So again, thank you very much. Thank you that you were together with us. Thank you. All right, so thank you all the participants, but I have one more question to Thomas from Vilnius. How it looks like in your country? Who performs the endovascular procedures? General vascular surgeons, radiologists, or angiologists? Explain us.
So
Thomas?
it depends from hospital to hospital. And so personally, I am performing both open and endovascular, also all these distal punctures and so on. In some hospitals, cardiologists are performing, but actually the share of the procedures is growing to vascular surgery field year to year. So I think it's shifting to maybe 90% will be vascular surgeries. So actually, we are doing the same interventions what we have seen, what Miguel Baker has shown us. So from technical perspective, it's the same. We are trying to measure oxygen, and we fail with these measurements. But yes, so it's the real life.
Okay, thank you. So next time you have to show us your case. I thank you all the participants for being with us. Thank you. So see you to the probably we will see you at the next webinar. Thank you.